it is already very in detail discussed that in various even conferences and various even in the published data is also that the NOACs are definitely effective and little bit the safer side as compared to the warfarin when you are preventing a stroke in atrial fibrillation. So, and you have a very vast experience regarding the use of the NOACs in AF conditions. So, what is your take on that? The NOACs are really doing the less bleeding as compared to the warfarin, or the data may be differ as compared to the Indian population?
No, I believe that when we are talking about bleeding in relation to anticoagulants or antiplatelets for that matter, we have to understand that if an agent becomes more potent, either as an antiplatelet agent or as an anticoagulant agent, it will certainly cause more bleeding. That's a double-edged sword, and that's a trade-off that you have to trade off between the thrombotic events and the bleeding events. So when we are talking about NOACs causing less bleeding, what we mean to imply, and we should train the physicians and tell the physicians specifically, that they are causing lesser bleeding, and especially intracranial bleeding, as compared to warfarin and standard therapies, because of the simple fact that NOACs are more specific inhibitors of coagulation pathways, whereas warfarin inhibits wide range of activities. So when we talk about lesser bleeding, I believe one point that has to be emphasized again and again is that NOACs are causing lesser bleeding as compared to warfarin, and overall certainly if the agent is more potent, it will cause slightly higher bleeding. So when we use the term less bleeding, we have to put this point also that it is causing less bleeding as compared to warfarin. That's my point of view on that.
Okay, so I think it's very well said. It's a more potent, then definitely effect is good, then there is a more chance of side effects also as well. Now the related to this bleeding part, in warfarin definitely you have to measure the INR, because it's a very variable when it's low, when it's high. So the measurement should be very regularly and infrequently, and according to that you have to change the dose. Now the claim on this NOACs part is that this practical issue can be sorted out with the with the use of the NOACs. There is no need of INR monitoring. So what is your take on this particular aspect?
No, it's true that, I mean, the advantage which some physicians perceive with the use of warfarin is that you can actually measure INR, and it gives you some sense of what the anticoagulation parameters are like and how much have we, and people become very comfortable if they get a warfarin, if the INR range in the normal that they want it to be. But that's one thing. Another thing that has to be brought in this discussion is that warfarin itself and the INR therapeutic window is very narrow, and many a times all of us who have been measuring INR with oral anticoagulations, with warfarin and with the other older anticoagulants, we have found that the INR measurement is highly unreliable, and with the same patient over days and over a same day you can have various readings. So this false sense of security sometimes may be disastrous for the patient. As far as patients not being sure of anticoagulation profile on the newer oral anticoagulation, it's like, I mean, it's there all in the mind. I mean, why don't we check antiplatelet activity when we are giving aspirin or clopidogrel for sense? So if the drug constantly proves over a period of time and in large multicentric trial that is having efficacious as far as the anticoagulation effect is concerned, I don't believe there is any rationale of us trying to say that just because INR, we cannot assess by easy methods the amount of anticoagulation, we should not go forward in using it. I mean, it has been shown over the trial that even if you don't measure anticoagulation profile, then too it works fine as far as the stroke prevention is concerned.
Okay, so it's very well said that regarding your concern on INR. Now the third thing is that bleeding. Definitely the warfarin has a major side effect of the bleeding, especially the intracranial hemorrhage, but it is also said that they have the antidotes. So I think this, even there is a one belief is that this drug can be it's effective, but when it's going beyond the safety margin, then we can have one arm in our hand to reverse the effect of a vitamin K antagonist. And as of now, the NOACs, the antidotes are not available in India. So when the bleeding is happening with the NOACs, then what is your take on to manage this kind of condition?
Yeah, I mean, to many skeptics, it would appear that not having an antidote is a serious handicap with the newer anticoagulants. So firstly, the antidotes are in the process of being discovered and tried in various. So we are having newer antidotes. Of course, they are not yet available for widespread clinical use and they are very expensive. But on the other hand, if you just look at the clinical aspect and what are the clinical scenarios we are talking about, I mean, many of these drugs are BID doses, so they are very short acting. So even when the bleeding occurs, and even when the catastrophic bleeding occurs, just stopping the drugs would, kind of reverse the anticoagulation within 12 to 24 hours. So it is only those bleedings that can really, kill the patient within the first 12 to 24 hours that we are talking about, and they are really limited bleeding. So they are close space bleeding, large intracranial hemorrhage. But here again, once large intracranial bleed has occurred, I mean, what antidote will probably bring it down? It's the management of stroke and its management of hemorrhagic stroke that will take precedence. And as it is, if you stop the neuroanticoagulants, the anticoagulation profile would improve within next 12 to 48 hours, and that should be it. So stopping the medication probably should do the trick. And in worst case scenarios, the antidotes are really coming up, and in few years we will see some antidotes for neuroanticoagulants also.
So definitely we are also hoping for some recent antidotes. If one is already approved in US FDA, and second one is under the trial, on the phase 3 trial. So very soon they should be available in India also as well. So I think now we have very crisp but in detail discussion regarding bleeding aspects when we are using the NOACs. And Dr. Sethi has given a very wide and experienced experience solution is given when the bleeding is happening with the NOACs, then what should we can do, what is the INR concern regarding the NOACs as compared to the Warfarin. So I think it's a very clinical rich kind of the discussion what we have as of now. So I think with this note we are ending our discussion. So thanks a lot Dr. Sethi for your providing valuable comments on this topic. Thank you.